everyone to ED Stop Suicide QI Collaborative Fireside Chat on safe and patient-centered care for children with mental and behavioral health conditions who are experiencing ED boarding. We are grateful to our HRSA colleagues in the EMS Children Innovation and Improvement Center. This collaborative and the Fireside Chat are supported by HRSA. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the US government. Thank you all so much for joining today's event. Attendees will remain on mute for the entire presentation. Nurses, social workers, and related professionals should put their first name and last name in the chat feature for contact hours. Please stay until the end of the presentation. You will receive details on how to obtain CE and contact hours. We also ask that everyone completes the session evaluation poll. The Fireside Chat is being recorded, and the recording and the slides will be posted online. Please feel free to add your questions into the Q&A feature at the bottom, and they will be answered throughout the presentation. If time permits, we will have discussion after the presentation. Next slide, please. This is a reference slide with the details on continuing education for physicians, nurses, social workers, and other professionals. You will see more details near the end of the presentation. I would now like to turn it over to my dear colleague, Dr. Mohsen Saidinejad.
Thank you so much. Can I go to the next slide, please? So just as a reminder that the Fireside Chat today is associated with the third of our 4 intervention bundles. This one specifically is the ED-based intervention. And the goal of this bundle is for all of our sites that are participating in this bundle to have established at least one clinical care pathway for children who screen high risk for suicide. Next slide. And these 4 that you see down here are specific quality measures that are specifically relating to this particular Fireside Chat as well as this bundle. Next slide. So it is my great honor and privilege to introduce 2 of my really great friends and colleagues with whom I've worked for several years, who are going to be our faculty for today's Fireside Chat. And it is a great honor to have them, a great privilege to be introducing them. First is Dr. Joyce Li. She's an assistant professor of pediatrics and emergency medicine at Harvard Medical School. She's also an associate pediatric emergency medicine physician at Boston Children's Hospital. She has devoted her entire career to the improvement of care of children in all pediatric emergency settings. In addition to her role at Boston Children's, she's also currently the chair of the New England Regional EMS for Children Collaborative and the Pediatric Emergency Care Coordinator Network, the PEC network. She has worked on several projects on the ground operationally with the general emergency departments, including regional needs assessment for pediatric behavioral health. And she has been instrumental in developing an online pediatric behavioral health toolkit that she's going to be sharing with us today. Our second speaker is Dr. Ashley Foster, who's an assistant professor of emergency medicine at the University of California, San Francisco, Benioff Children's Hospital. She practices both general emergency medicine and pediatric emergency medicine. She has great passion about enhancing and improving emergency care of children, youth, particularly those with mental and behavioral health conditions. And she has conducted several research projects within the area of emergency department boarding, agitation, and the use of restraint in the emergency department. She was also part of a steering committee that created the New England Regional Behavioral Health Toolkit with Dr. Joyce Li, which also will be a part of the discussions today. So with that, I would love to pass this on to Dr. Foster, who will take us from here on. Ashley, to you.
Thank you so much, Mo, for that wonderful introduction. And Joyce and I are just so excited to speak to you all today and really impressed with your dedication towards improving and enhancing the care of children with mental and behavioral health conditions in the ED. I'll have you go to the next slide, please. So we're going to start off by learning a little bit about all of you. And so we have 3 questions that will show up here momentarily in a poll. We'll give about a minute for you all to complete it. They will be anonymous. And it will help us to really understand who you are and your ED environment. So we'll give you about a minute now. Give just a couple more seconds here. Thank you so much for everyone who answered the poll. If we could, Louis, show the results of the poll. I don't know if everyone can see.
Yeah, I'm not sure if it's showing up for me.
Well, I am happy. I don't know, Louis or Christina, if there's a way to show the results, but if not, I'm happy to read them. So the first question was regarding the ED environment, and of the individuals who completed the poll, there were 45% work within a general ED, 15% work at a separate pediatric ED within a general ED, 30% work in a pediatric ED at a children's hospital, and 2 felt the question wasn't applicable. The second question was, how many of you have had a child boarding in your ED for mental or behavioral health symptoms for greater than 12 hours in the past week? 75% of you said yes, with 15% saying no and 10% felt it was not applicable. The third question, how many of you work in an ED that regularly uses 1 or more safety tools for children who are experiencing mental health boarding? 70% said they work in an ED that does have at least 1 safety tool, with 20% saying no, and 10% saying not applicable. So thank you so much to everyone for completing this poll. And with that, I will move on to the next slide. So in the next 30 minutes, Joyce and I hope to review the landscape of pediatric mental health boarding and introduce resources that can be utilized for children with mental and behavioral health conditions while they're experiencing ED boarding. We also will discuss and share real-life examples of implementing the tools within the ED setting. Next slide. Mental and behavioral health conditions in children are common in the US. In fact, approximately 1 in 6 children and youth has a mental and behavioral health condition. Currently, there are many challenges children face in accessing care before coming into the emergency department. For example, studies report 50 to 70% of children with treatable mental and behavioral health disorders do not receive care from a mental health professional. Additionally, there's a shortage of pediatric trained mental health professionals that is currently predicted to worsen in the short term. This has meant significant increases in ED utilization for children in mental health crisis. Once in the ED and after an evaluation by an ED team and mental health specialists, if it's determined that a child requires inpatient psychiatric hospitalization, the child may face a prolonged length of stay, which we all know as ED boarding. In 2020, there was a systematic review that reported that 23 to 58% of children awaiting inpatient psychiatric care experience ED boarding, and the average boarding duration is 5 to 41 hours. During boarding, children are at risk of safety events, such as medication errors, and may have limited access to mental health care, as well as activities of daily living, such as scheduled meals, showers, or age-appropriate activities, and are at risk of developing acute agitation episodes. Next slide. The COVID-19 pandemic has unfortunately had a major impact on mental health for both children and adults. And studies have shown increases in pediatric depression, self-harm, anxiety, and eating disorders since the start of the pandemic. Although the total number of pediatric ED visits initially downtrended during the start of the pandemic, the proportion of mental health ED visits in adolescents increased, particularly for those with suicide attempts among girls 12 to 17 years of age. Also, even though the length of boarding was already increasing pre-pandemic, studies confirm that there's been a further increase in lengths of boarding time for children and youth. Next slide. Many of us on this Zoom work in EDs and have witnessed the challenges to optimal care of children in mental or behavioral health crisis. We hope to better describe these lived experiences and also tap into the expertise of staff that work in EDs in urban and non-urban settings with varying pediatric annual volumes. We conducted a qualitative needs assessment to better understand ED staff experience caring for children with mental health conditions, and also asked for suggestions of potential resources that may be helpful to enhance care. We interviewed emergency department pediatric emergency care coordinators, or PECs, and these are pediatric champions of the ED. And we discovered three main themes. First, frustration with barriers to care and limited resources, moral distress of ED staff due to these barriers, and the perception of negative impact on other ED patients. Next slide. Fortunately, during these interviews, participants suggested a wealth of resources that did not currently exist within their ED that they thought could help enhance the care of children with mental and behavioral health conditions. Interestingly, the resources targeted different audiences, as you can see, into four categories: patient resources, caregiver resources, ED staff resources, and ED administration resources. Some of these suggestions focused around communication and guidance on the best staff or best approach to a child in mental health crisis. Next slide.
Thanks so much, Ashley. And thanks again for having us. As Ashley said, I'm really excited about this. And I think it's really everyone should be committed for participating in this to enhance the care in your hospitals. So the next step after the needs assessment was to do the behavioral health toolkit. It was designed specifically with the goal of targeting community emergency departments that have limited resources, including limited or no access to child life, child psychiatry, child behavioral health teams, anything of that sort. We actually sent out a couple of polls after that assessment. As you saw, there were lots of things on there, and the things that rose to the top of what people wanted was an activity resource packet, behavioral health videos or more introduction to that, and then the comprehensive care bundle. And we're going to talk more specifically about those two things in just a second. But we really wanted to make sure that this was going to be easily accessible. As you can tell at the top, it's available free online. And one of our main to try to also make these things very easy for people to use that would not just easily accessible, but also easy to use. Next slide. So the first resource that we came out with was the resource bundle. And so there are really two items in here. The first one is the activity binder, which I'll go into more, but basically this requires no funding, no special training. These are activities that are inside a binder, which I'll go over in a second. Essentially, if you have a printer and a binder to put them in, you can make this yourself. They're all self-guided activities, so it doesn't even require staff necessarily to be there. Certainly, staff could use it if they wanted to, and we'll talk about more about what's in there. In addition to that, we also made a purchasing guide. So one of the points of feedback we had received is a lot of people had said, you know, we have literally nothing. Money to buy things, but we don't even know what would be safe, what's appropriate. Again, we don't have child life, we don't even have pediatrics to help guide us as to what to even purchase. And then as the part of trying to make this very easy for people to implement in their EDs, we did include a script, not just for parents, but actually how to introduce these activities and these purchasing guide to their staff. We included an email template that people could use, so they could literally just kind of copy and paste, insert whatever was appropriate for their ED. We included a flyer. And then overall, there's an introductory video to this entire resource that kind of walks you through all of the different items. Next slide. So this is an example of some of the things that we had in there. So this this is things that people could buy. There's actually even a spreadsheet with Amazon links and other even more specific things that you can go to and just purchase on your own. These are things that have been vetted by Legal Child Life, a variety of different people, as things that were thought to be age appropriate, and B, generally safe. And as you can see, there are a few things that were deemed that that only for select patients that a psychiatrist or someone else has said is okay for them to use. But the vast majority of these are things that were deemed safe for essentially all of the patients within that age group, and is something that you could purchase if you wanted to. Another thing that was also in the purchasing guide is there's a little kit list. So a list where you could have 5 items if you want to just make an activity kit. The nice thing about this is that really this isn't just applicable to pediatric patients coming in for a behavioral health concern. Really, you could use these for any patients. And we actually got feedback from some hospitals that said they actually use it just for a pediatric patient that is coming in and might be in the ED for a while. Next slide. So this is the self-care binder, and this is just a couple of things that are in there, but basically there are really 3 categories of things. So the first was communication boards, and what those are, if you've ever seen them, is it's literally just a piece of paper that has the letters on there, the alphabet A through Z, or it's basically a grid with different pictures on it. So say a picture of a walk, a picture of TV, something like that. And what these communication boards, they're obviously very useful for our autistic patients, developmentally delayed patients, patients that are nonverbal at baseline. But the goal of this was also actually because there are certain patients that are usually verbal, but when they're in a mental health crisis, they may be nonverbal or may not want to communicate verbally. And I know from personal experience, we have used these communication boards with those patients who still want to communicate, but just are not in a mental health space to be able to communicate verbally. So those have actually been very helpful, and obviously very helpful with the autistic developmental delay patients that are able to learn a little bit, or maybe actually already use this to a certain extent. The next category were mindfulness and gratitude. And so these are exercises that people can do in the ED. Most of the mental things, but there are other kind of mindfulness gratitude things. And the example would be, for example, they give you a list of one of the gratitude exercises is to think about, is there someone in your life that you're grateful for? Is there an event that you're grateful for? Is there something that's happened in your life that you're grateful for? And the nice thing about these exercises is that, again, not only can they do this in the ED very easily without any cost, but it actually is starting to them in some exercises that potentially will help them later. Mindfulness is also kind of the same idea, these idea of just kind of recognizing where you are and being able to hopefully have some more insight into your own kind of emotional state and helping to learn self-soothing techniques. The stretching breathing exercises are a little bit related to that. So there are some yoga exercises, very basic ones that do not require any special, I hesitate to call yoga because some yoga could certainly requires more experience. So the really kind of stretching exercises, particularly for patients that are in one space, they basically can't leave that space for a very long time. This actually gives them something physical without being really kind of like true exercise. And then there are breathing exercises. And so one example is here. So you can probably see this on your screen. The thing that you're looking at is called a finger labyrinth, and it's actually something you can use as a breathing exercise. So you actually trace out the pattern with your finger, breathing exercise with it. So you either take a deep breath, hold your breath, and trace out the whole finger labyrinth with your fingertip, or you can take a big breath and you breathe out, long, deep breath as you trace it out. And so again, these are self-soothing exercises that can be used in the ED, but potentially they could actually learn how to use them even after they leave when they're in a better mental state. Next slide. So one thing that we did is the Vermont state, just in general, have really made it a priority to better care for pediatric patients with mental and behavioral health conditions. And so not just within the ED, they've done other programs that are really amazing with primary care providers and trying to support them as they have very few child psychiatrists. And one of the things that they did is they felt that this activity resource was really something that they wanted to support and thought could be really helpful. So a specific program state called the Vermont Program for Quality in Healthcare, which is a nonprofit organization, basically provided funding, and they actually created the kits, printed out the self-care binders, and distributed it to all of the EDs in Vermont. And the feedback so far has been pretty good. Basically, staff have really liked it. The staff feel like families like it. And again, I think this really addresses one of the main moral distress concerns that we saw in the needs assessment, at least in our area, is that people felt very helpless. They like they had anything to really give to these families. And so having these have been really helpful, I think, from both a more distress standpoint, but then for the families themselves to actually give them something. Not only does it, I think, not only does it empower the staff, but I think the families themselves feel some degree of that they are being heard, that they're being recognized as a human being in a situation that's very difficult, and that the EDs are trying to do more. Next slide. And then I'm going to turn it back over to Ashley.
Thanks so much, Joyce. So the comprehensive care bundle is another one of the main components of the New England Regional Behavioral Health Toolkit. And most elements within this bundle were initially created for Children's Hospital, ED. And it was created after the ED saw a threefold increase in adverse behavioral health events in the setting of higher volumes of children with mental or behavioral health crisis. After key drivers of events were identified, working groups were formed in areas of safe room entry, observant monitoring throughout the stay, as well as accurate medication delivery, active mental health engagement, and personnel safety. And after implementing the bundle, the ED was able to reduce rates of these adverse events. To adapt the tools to all types of emergency department settings with varying personnel and resources, an expert panel was formed that comprised of nurses and physicians who worked in a general emergency department environment. All the tools were reviewed, and if not immediately felt to be both appropriate and helpful, they were modified based on expert panel suggestions. Additionally, patient-facing tools were reviewed by caregivers of children with mental and behavioral health conditions who have experienced boarding in the emergency department. Suggested modifications of some of the tools included ability to use the tools a la carte or as needed, depending on the unique needs of an emergency department. Also, the ability to individualize the tools for each unique ED environment, acknowledging that ED environments may have different resources and personnel. Additionally, including explanations of some of the tools on how ED staff should introduce or utilize these tools was suggested. And finally, a modification to some of the tools was allowance of the tools to be used not only among nurses and physicians, but also the multidisciplinary ED team. Next slide. The comprehensive care bundle has resources that can be grouped into safety and patient-centered care. And ED may not necessarily need all of these. And it sounds like for many of you, your ED has at least one safety tool, which is really fantastic. And so an ED may not need to use all of them, maybe some of them, maybe have some of these and would maybe want to make modifications. And so these tools can all be adopted to fit the specific needs of an emergency department. Over the remainder of our time, before we get to the Q&A section, I'm going to briefly introduce each of these tools. And in thinking about how to potentially best implement these tools within an ED, I think it could be helpful to think about who exactly is responsible for completing the tool or form or checklist, if the tool needs to be updated throughout a patient's stay and how often that will happen, and where the tool will be kept in the ED. For example, will it be put in an electronic medical record? Is it a paper copy that will be live in a patient's room or potentially a patient's chart or folder? And all of these answers may depend on the specific needs of an emergency department. Next slide. The ED safety room checklist is the first of the tools that I'm going to highlight. As Dr. Hoffman introduced in her Fireside chat a couple weeks ago, It can be really helpful for an ED if there are predetermined safe rooms that have features such as garage doors that can be raised and lowered to cover equipment as needed. However, many EDs don't have this option and don't have safety rooms designated or don't have enough safety rooms. And unfortunately, there are many elements of a typical emergency department room that can have potentially dangerous items such as trash cans, oxygen tanks, items with straps, extra chairs. And this safety room checklist was created specifically for rooms that are not previously designated as safe rooms. Ideally, the safety checklist is completed by one of the ED team members before the patient arrives into the room. And details within the checklist can be modified and changed based on what is typically included within an individual ED's room. Next slide. The behavioral health intake form is best used at the start of a patient's visit. And this tool really serves a twofold purpose. First, it serves to check to ensure appropriate safety precautions and screening has occurred for the patient. And secondly, it serves as a communication tool among the ED caring for the patient while boarding. And really important elements of this includes, it does cover medications and timing of medications. And so for that medication check, this is the great tool for that. Next slide. The next tool is both a handout for caregivers and a script for difficult conversations for ED staff. The handout was displayed in your Stop Suicide Bundle Guide 3, and it covers common topics that come up during a child's stay in the ED and can provide valuable information on what to expect in the ED. We were fortunate to get parent input when we were modifying this form. The second part of this tool is a difficult conversation talking points guide. And this guide is not meant to be given to caregivers, but meant to be actually used by ED staff as an aid to facilitate difficult conversations. Topics that are covered in the script include explaining different levels of psychiatric care, explaining long ED boarding times, and explaining involuntary holds. It's important to understand state and hospital specific rules around involuntary holds before using the script. And so we recommend discussing involuntary hold hospital policy with both your mental health clinician as well as either hospital leadership or the hospital legal team. And this will really help to best facilitate staff conversations with caregivers. Next slide. The next tool is a daily behavioral health tracking form. And as you can see here, this is a grid that ensures activities of daily living are occurring and also that the ED team is regularly assessing for safety. And this tool also can be used as both a checklist as well as a communication tool among staff between shifts. And the grid can include information about activities of daily living such as toileting or showering, but all with a focus on safety. The column represents an opportunity for the assigned ED staff to check off if tasks or activities have been addressed or performed. Next slide. The coping tool is a resource that aims to help in the delivery of individualized patient-centered care. Patients and/or caregivers can help to identify potential triggers in the ED environment that may cause distress to the child, such as being hungry or having the lights turned off. This form also helps to identify symptoms of distress that are developing in a child, and importantly, helps to identify the child's coping strategies for when the child is developing distress. This information can be really valuable to the ED team in avoiding or trying to avoid potential triggers. And then if the patient starts to develop symptoms of distress, the ED team can help to assist the patient in their coping strategies to prevent or reduce agitation episodes. And as you can see, it includes pictures here as well, in case pictures are a better form of communication for the child. Next slide. So this next tool is a daily schedule. And this tool is paired with the Emergency Nurse Association handout about providing safe structure for pediatric behavioral health patients in the ED. A schedule was briefly covered, or using a schedule was briefly covered in one of the other Fireside chats. And the really nice thing about a daily schedule template is it can be used to provide expectations and structure to a child's day, and also can potentially empower the child to make some choices regarding safe activities during their stay. It can be displayed in the room, potentially so that the child can see and know what to expect. And the tool pairs really well with the activity resource packet that Joyce reviewed, which has the options for potentially movement exercises or activities and patient-safe and age-appropriate activities that can be incorporated into this schedule. Next slide. So the behavioral health handoff tool is a safety tool that ensures important and necessary information is passed along during a sign out or handoff at ED staff shift transition. And the IPASS model has been shown to improve communication quality when used in an emergency department environment. The particular IPASS tool that's included in this bundle has been adapted to specifically serve children with mental and behavioral health conditions. Next slide. So the next tool is a behavioral health safety rounds guide. And this can be seen as a behavioral health huddle. Implementation of safety rounds or safety huddles can ensure the ED team and patient and caregivers are up to date on the patient's care. Can also be used to discuss daily medication updates or changes, if safety events or agitation episodes have occurred, and potentially review new information about triggers or identified coping strategies for the child. We recommend that this be performed twice a day, but it can be adjusted based on the needs and the resources of the individual ED. Particular considerations for this tool may include how it can be incorporated into the workflow of the ED, determining what specific or who specifically should be part of the huddle, and if there are additional pieces of information that are important or relevant to share on a daily basis for children who are boarding. Next slide. The final tool is the core principles of behavioral health care. And this is really an informational sheet that can serve as a guide for ED staff on principles and approach to care of children in behavioral health crisis. Topics covered include stated goals around providing safe, patient-centered care in the ED, as well as recommendations around using the least restrictive approaches to agitation, and helpful tips on how to potentially modify the ED environment to reduce distress or agitation, including verbal de-escalation strategies to use in a child in distress. This tool could be used and reviewed with new staff during the onboarding process. It could also be potentially posted in a common space, such as a staff workroom, to help remind staff about tips on how on these specific tips. Next slide. All of these tools are available online in the New England Behavioral Health Toolkit website. And as Joyce mentioned, this is available to all. These are free, can be downloaded, can be modified. And that way that it can meet the individual needs of an emergency department. Here's the website where you can find the toolkit. And I know Joyce and I covered a lot of information, and we're really excited and happy to take questions from the group.
So one of the things, just as we're waiting for people to see if anyone has any questions, I think one of the things is, and Ashley alluded to this already, which is that it can be really, really daunting. Any of these things on its surface look very appealing. It can be really hard to think about, how am I going to get people to buy into this? How am I going to implement it in RED? And, I think everyone here obviously knows their EDs and their hospitals and whatever practice care, whatever organization you're with very well. But, sometimes you can do something as simple as saying, there are some resources we have. Is there something that even just polling your own ED, not like a formal poll, but just saying like, hey, there are these things that are available. Do you think this is something that would be helpful for you? Might even be just the easiest way to start out. I think there is so much to tackle when it comes to pediatric patients who come in for a behavioral health condition. And if you don't have a lot of resources, trying to figure out what is the best way to approach them, that sometimes just polling your other ED staff or your other hospital, or again, wherever you practice, to think about, where is the best place to start, is sometimes just asking other people for their opinion and where they think it'd be most helpful.
All right, thank you so much, Ashley and Joyce, for this amazing talk. So we wanted to, as mentioned, open it up to question and answers. There's a couple of things that already have come up. So Ashley, I wanted to ask you first. You had, in the very beginning, when you put up the poll, you had mentioned about a safety tool. Do you have access to a safety tool? Do you work with a safety tool? One question from the audience was, what do you exactly need to have to qualify as a safety tool? What is the definition of that?
That's a great question, Mo. And I think that question was meant to be intentionally vague because it can mean different things for different emergency departments. And certainly thinking about fundamentally what a safety tool would be, it's to enhance the care of a child with a mental and behavioral health condition, which could mean trying to reduce medication error, could mean trying to reduce harms to not only patient or family in terms of agitation events and restraint, could mean to provide patient-centered care. And so all of these could potentially be considered safety tools. And there's really such a vast number of ways that we can think about enhancing the safety of any patient in the emergency department, but specifically a child with a mental behavioral health condition. And so that's why it's really exciting, because there's just so many ways that we can all tackle enhancing safety. And hopefully some of these tools can inspire some work towards enhancing safety.
Excellent. Thank you so much. Joyce, question for you. What might be a best way to roll out these items that you mentioned in your comprehensive care bundle? There's a bunch of different things. And question is, is there a specific certain order that might be best to launch these, or is it ED specific? And a question related to that is, if you didn't have the ability to do all of them, what would be the first thing? What would be the one that you have gotten the most positive feedback about in terms of items within that comprehensive bundle that you should start with?
Yeah, I think actually, so the first thing is I would actually encourage no one to do all of them at once. I would actually say if that is your goal, you should not do that, because I think it'll be a lot, and I think it would be very overwhelming, and you'll put in all this effort trying to institute all of those tools. You find that it is so hard that you may just be like, I can't do this. So my actual suggestion would be, please don't try to institute all of those tools at once, because I think it's change is hard. And I think most ED staff, if they're like, oh my God, we now have to do 8 of these things, would be very overwhelming, just not going to buy into it. The short answer is, I do think that the best way for people to do it is to look to see what they already have. Part of the process of when we made that comprehensive care bundle, which I think Ashley mentioned, but we pulled a lot of other community. We did a formal Delphi actually with community ED nurses and physicians, and it was very variable. Some people would say, we already have half of these things, and then others said, we have none of these things. And so that's one of the reasons why we made it an a la carte menu, and why we don't say specific, start with this tool, then go to this tool. Because I think all of those tools have benefits to them, but a lot of EDs may already have something. If someone has literally nothing, so like absolutely nothing, has none of the tools that we already have on there, I actually think for my personal opinion, would be the 2 tools I think are the potentially easiest ones to implement, that I think will get a lot of positive feedback from families, and also which will in turn cause positive feedback with the staff, is the what to expect tool. It's pretty easy, it's straightforward. You only need to update a little bit of it for your specific site. A lot of people said that, and I suspect this is true of most EDs and hospitals, which is that when these patients come in, they are going to wait a long time. And if they are not familiar with that process, they are very, very much very agitated. They're like, why is this not happening quickly? And not understanding that this is a marathon, not a sprint for these kinds of ED visits. The other one I think is really potentially very helpful, and again, I think very good, is the coping tool. I think filling that out really can set the stage for, I think it not only sets the stage of communication, that you're a team, that you're going to work with the family, that you want to understand what the child is doing. And it's something that I think help empower the family. And then if you keep that with the patient in their patient room, it's fairly easy to read and go through, and staff can very easily look at it and say, okay, I just want to know what is a trigger for this patient or what works well with this patient, and it would be there right away. And I think fairly will empower the staff to at least feel like they have some degree of knowledge on how to interact with those patients, but also the family will feel heard, which I think they don't feel in these situations, and also feel like, oh, this ED actually wants to do well by my child and is trying to do something well by my child, but I think is also very easy to enact. It's not likely to cause any further issues. I think requires probably fairly minimal input from more than just like the provider and the parent and the patient. But Ashley, what do you think? Any other thoughts?
Yeah, thanks. I was going to echo. I agree that in my opinion, probably that's a great place to start in terms of the what to expect and the coping tool. Just thinking about delivery of patient and family-centered care. I think that another way, I know Joyce had mentioned this already, but it is a potentially really great way to get staff buy-in and feedback in terms of what staff thinks are the most urgent and pressing issues that can be addressed, which could be potentially through a survey or a poll. Doesn't have to be anything formal, and certainly could be really helpful to sort of see what the needs are within a single emergency department. One strategy to think about what is potentially most urgently needed, which is what the emergency department did that sort of inspired this bundle, is thinking about adverse events and thinking about what the specific adverse events are within an emergency department as it pertains to children with mental and behavioral health conditions. And so maybe if it's more around safety events because of room safety, then the room safety checklist would be really the best place to start in terms of thinking about how to immediately address problems and issues that have come up within an ED. Potentially, if there are challenges around administration of medications or updating medications, then something like the daily behavioral health tracking grid could be really helpful to make sure that the ED team is all on the same page and has updated information regarding the patient and within the patient's stay. So the really great thing is that it may be different for different EDs in terms of what is top priority. And I absolutely echo Joyce that this was never intended to be, these are all the tools, please start using all of them now. That's just really not realistic, feasible, or probably helpful. And that probably introducing one, maybe two at most at one time is really a great strategy to use.
Excellent. So the next question again for either one of you guys, the comment, this is a great toolkit. How did you and your hospital implement this among the staff and the providers? How do new employees and providers get this information?
Yeah, I can talk about that a little bit, and Ashley can talk about that as well. But I think that as far as like employing the ED, I mean, as Ashley had mentioned, the reason that some of the comprehensive care bundle was initially initiated was because of reaction to or addressing adverse event. And so it actually was helpful because time, the staff were actually very motivated to see some of these tools. People recognized within the ED that this patient population was not being adequately cared for. Their needs were not adequately addressed. So that always helps, obviously, if you've already kind of got that setting. As far as like within the Vermont, there wasn't necessarily a specific call for this. They certainly were a part of the regional needs assessment. And so that was an advertising campaign. One of the things that we did try to do is if you have a pediatric emergency care coordinator at the ED, they were the ones who really championed this. And so they often would reach out to other staff. They talk to other staff about having this resource available. Again, either through emails, faculty meetings, just making it well known within their ED. And just making sure that these things were available in kind of a well-lit area, kind of a high trafficked area staff were. And then also just kind of following up, making sure that people are aware that these things were there. Usually if there's a positive, at least with the activity toolkits, I can say, once you have a positive reaction from a family, it's much easier to kind of move forward with it. And people tend to share that with other people, right? They say, oh, I used it and it was great. The family really liked it. And so you really just need a few positive interactions. And I think it starts to grow within the staff. Oh, this is great. We should definitely use this, or I used this before and it worked so well. Let me use it again. And so that's one of the reasons why with a comprehensive care bundle, I do think the what to expect and the coping tool, the nice ones to start with, because more likely than not, you're going to get a positive reaction from families. And also will in addition to that, will hopefully help you grow that to more activities like this came, we had a great experience with this, and here are some other tools from that same bundle.
Excellent. And I just have one final question on the mechanics of this. So if somebody in their institution wants to use these forms, are they allowed to use their own hospital logos and things like that and pass it off as something that was developed there? Or is there permission requirements? For example, whenever you have the Boston Children's logo, that needs to stay. And can you just talk a little bit about the intellectual property piece of this? I know this is an open access, but just to clarify for everybody that there is or there isn't a permission required for doing anything, especially even if somebody wants to put their own hospital logo on.
Yeah, Ashley, if you want to start, and I can address it as well.
Sure. So I think that big picture, these are meant to be modifiable or can be modifiable, and they specify on the website their specifications in terms of if there's any elements of the form that are meant to be on the form or remain on the form, which really is to make sure that appropriate credit to the originators of the form is given. And so the answer is yes and no, in that they are definitely all modifiable, but some of them it's requested that elements are kept on the form just out of respect for those who created it. I don't know, Joyce, if you want to add anything to that.
And this is pretty clear for them to know. They don't have to reach out to you to clarify. This is fully explained.
Yeah, it's really to credit the people. So there were a group of nurses that really put in a huge amount of effort in making these forms, and we felt it was only appropriate that they receive appropriate credit for all their hard work. And so for me in particular, I would say that's the part that we just would like to keep, or would like people to keep, just so that there is some acknowledgement for them. I think, and Ashley, we've never talked about this extensively, but as far as within internal use, if someone's using it internally within their hospital, what is most important to me is that they're using it. And so if at the end of the day, the only way their hospital is going to, basically, if the only way their hospital is going to use that form within their hospital is they say you have to put, their logo on it, I don't necessarily have an issue with that. I think we have more, the question of keeping the credit definitely comes more with if they're going to start presenting that outside of their hospitals, then, we want to make sure that those nurses get the appropriate credit for what they did. And there were also child life people, there were child psychiatry. There are a lot of people that really contributed a lot to these tools. And we just want to make sure that they get recognized for their work outside, but the internal use, for me, the internal use part is that people are able to use it.
100% agree. We just want these to be helpful for everybody. And so, you know, that's why they're open and available online. So.
Thank you so much to the both of you. Really, really appreciate this awesome session and the response to the questions from the audience. I'm going to go ahead and pass it back on to Christina to talk a little bit about CE credits and some shop talk, I guess.
Here are details on credit hours. I am about to include the link on the chat. I want to thank each of you for joining this fireside chat. The slides are being recorded and will be posted on our website.
And Christina, I just wanted to say one other thing, if that's okay. I know our email was shown at the beginning, but Joyce and I are always happy if there's any questions that ever come up. Please don't hesitate to reach out and email us. We're always happy to discuss and engage as it pertains to the Behavioral Health Toolkit. And we really appreciate your time and wish you the best of luck in this collaborative.
Yeah, I already put my email in the chat. It's on our toolkit as well. So as always, feel free to reach out to us. We're again, we know how hard it is. We know that change is hard just in general, but for relation it can be particularly challenging. So we are happy to answer any questions or provide any assistance as anyone needs. And again, I applaud everyone in this group to even be on this call and to be thinking about this and trying to help this very vulnerable population.
Thank you, Dr. Foster and Dr. Li, for this amazing and valuable presentation. I would like now to ask everyone to complete the evaluation poll.